Hello, hope you all are doing well. My name is Ryan Lashover. I'm the Assistant Program Director at Waco Family Medicine Residency in Waco, Texas. And over the next 30 minutes, I'll be sharing with you the Waco Guide to Psychopharmacology in Primary Care. I have no financial disclosures to discuss ahead of time. Specifically, this work was funded by the Episcopal Health Foundation, and I want to highlight that this project was not funded in any way by the pharmaceutical industry. We have 4 objectives to talk about today. First, we'll review the current landscape of behavioral health care. Next, we'll explore clinical decision support as a unique tool in implementing guideline concordant care. Next, we'll conceptualize how the Waco Guide to Psychopharmacology in Primary Care may be woven into your healthcare system. And lastly, we can contemplate how this model can be replicated across other disease processes. Mental health care in our landscape currently has many challenges and opportunities. What we see is roughly 20% of adults experience mental illness yearly, and primary care is the de facto mental health service in the United States. However, primary care clinicians are undersupported in this role. 2/3 of primary care clinicians cite that they have difficulty referring to specialty mental health services when desired. There's been many proposed solutions, and one of the ones that's really risen to the top when Dr. Mark Alferson talked about mainstreaming mental health care. But there's many barriers to mainstreaming mental health care. Some of the biggest are that guidelines published for psychiatric disorders often do not translate easily to primary care clinicians. Most of these are made for psychiatric specialists, and this is different than other areas. This is different than AFP, AAP, ACOG, when they're written with the primary care clinician in mind. Also, there's some studies that report that primary care clinicians cite discomfort in prescribing psychotropic medications. And so, like many of y'all, we ended our clinic days and our resident staffing days saying, how do we do this better? You know, we have a high prevalence of psychiatric illness. We have PCPs that are hungry for further training, but also with limited time. And so we said, how do we do this better? How do we provide top-notch care to some of the most stigmatized and marginalized disease processes? How do we improve training? And ultimately, how do we deliver this to the point of care in an accessible condition or way? And so we looked to clinical decision support tools as a medium to meet this solution. Clinical decision support tools are tools used at the point of care to provide high-yield recommendations. They've been made notable by the Institute of Medicine, as well as the chronic care management model highlighted by Dr. Wagner. And in its essence, what Dr. Wagner talked about is translating guidelines into care. And so he highlighted that guidelines only become effective when they're integrated and woven into the fabric of patient care. And so we use this model, and over the last few years have worked to develop the Waco Guide to Psychopharmacology in Primary Care. This is a collection of 60+ psychopharmacology decision support tools encompassing routine and complex mental health disorders. This addresses the spectrum of adult, pediatric, pregnancy, and elderly populations. Additionally, these tools take into account comorbidities such as renal, hepatic, cardiac impairment, as well as obesity. It addresses substance use disorders, and the Waco Guide is routinely reviewed and updated. I'll share a little bit more about the process of creating these tools in a second, and we'll walk through some example tools. But I'd like to highlight in the beginning that this is a partnership between faculty of the Waco Family Medicine Residency, as well as faculty of the Harvard Massachusetts General Hospital Psychiatry Academy. These are often considered the top experts in the different disorders and fields that we addressed. There's some core tenets that are worth highlighting before we unpack these tools. First, utmost, these need to be reliable. These need to combine top-level evidence and expert opinion with real-world primary care experience. They need to be succinct without compromising the quality. These need to be accessible at the point of care in the exam room. The tools have a focus to cost. When multiple options are on the table, but one costs significantly more or less, that's addressed. The scope we discussed before across the adult, pediatric, and perinatal populations. And very important to this project is that this is an ethical project with no industry funding. So I'd like to peel back the curtain shortly to talk about the process of the creation of these tools. So let's start with major depressive disorder. And when we start there, we look at the top clinical guidelines in the high impact literature and assimilate those into our first draft of our decision support tools. Then, like we talked about before, these guidelines may not be written as clearly for primary care clinicians always. And so we offer the primary care lens to interpret those guidelines and apply to primary care. Next, we took those two options or tools combined to two independent consultants. And if you all have sat in a room with two individuals at the top of their field and often the most published in their field to agree on one thing, that can be a tall ask. But it also offers significant credibility to the project. And so we had two independent top of the field experts from Massachusetts General Hospital agree on a final tool. And then we met for a final review again to review the tool all together. I'm going to show some examples of a few tools in a second, but what we quickly figured out is a video explaining the Waco guide and the tools may do a much quicker example of what these look like. And so I'm going to play this video. It lasts less than 2 minutes. Here we go.
The Waco Guide to Psychopharmacology in Primary Care is a tool developed by the faculty of the Waco Family Medicine Residency Program in consultation with the faculty of the Massachusetts General Hospital Psychiatry Academy. As you navigate the site, please keep a few things in mind. First, the tools are intended for primary care settings, where access to psychiatric support is limited. Second, these tools assume an accurate rendering of a mental disorder diagnosis. Third, these tools should be used to supplement, not supplant, clinical judgment and recommendations from authoritative professional bodies. Over-reliance on this tool may lead to errors. In the end, no tool is a substitute for independent clinical judgment, informed by medical knowledge and expertise. Each decision support tool starts at the diagnosis and moves in a logical, linear fashion from top to bottom. Generally, a standardized color scheme reflects different treatment options, such as red for first choice and green for second choice pharmacotherapy. In instances with multiple options, but one medication is preferred over another, due to either efficacy, tolerability, intensity, or expert opinion, this is denoted by numbering. A second page that includes titration schedules and side effects accompanies each tool. Please be aware that the side effect list is not exhaustive and should not replace the typical review of side effects and interactions performed in standard practice. As methods evolve and further decision support tools are developed, you can find the most current edition of the Waco Guide on the website or app, and feel free to contact us with any questions, concerns, or recommendations on how to improve the tool in future editions. We hope the Waco Guide is readily applicable and helpful to your practice. The Waco Guide.
All right, so that's your intro to the Waco Guide. So the Waco Guide to Psychopharmacology in Primary Care can be accessed in two ways. The first is our website, which we're going to look to next. And the other way is our app, which I'm excited to share after we look at the website. So I'm going to follow this link here, wacoguide.org. And you'll be taken to our homepage here, and we're going to walk through a few aspects of the webpage. First, this play button here is the video that you just saw. So if you're wanting to share this less than 2-minute video with anybody to get them up to speed on the project, great option there. Next, there's the guide we'll look at, the app to download the app, and then the survey. The survey is a psychopharmacology decision support tool survey that we are using to study with our research partners at Baylor University to study the implementation of these decision support tools. And we're studying how these change practice. Our hope is that in a couple of years that we can share with you a robust sample size that clinical decision support tools are an effective means to implement guidelines, and that evidence can be used to support other opportunities to look at other areas of clinical decision support tools as well as potential funding as well. Let me click on the guide here. I'll point out the 4 different sections: adult diagnoses, pediatric diagnoses, perinatal and women of childbearing age, and substance use disorders. And let's look at a couple of these together. So under adult diagnoses, you'll see a long list of different diagnoses here. I can start with potentially post-traumatic stress disorder, and you'll see a top to bottom approach to treating PTSD. A few areas to highlight are the different colors. So blue is pre-treatment questions, orange is non-pharmacologic interventions, red is first-line pharmacotherapy interventions, this lighter green is augmentation therapy, and then the darker green is second-line options. You'll also see a page 2 which has dosing information, titration schedules, side effects. Again, this is not an exhaustive list and should not replace your typical review, as well as some nuanced guidance to other areas. I'm going to go back to the Waco Guide page here, and I'm going to click on bipolar disorder. So let's look at bipolar disorder. You'll see bipolar depression, bipolar mania, when things cross over from mania to depression, how to think through those treatment options. I want to highlight a few other areas as well in these decision support tools. We have elected to use the AFP's citation system of assigning levels of evidence to different key treatment steps. So here, for example, treating bipolar depression, here's a sort A, which means high quality and robust evidence towards atypical antipsychotics and lamotrigine, with a specific sort A recommendation for lurasidone having a robust evidence-based. You'll see other areas that may have a sort B or a sort C recommendation as well. These sort recommendations then refer to our bipolar recommendations and references page that may talk about areas such as use atypical antipsychotics or lamotrigine over mood stabilizers for first choice treatment of bipolar depression, just like we saw before, as well as the references. These type of references and citations will be on every decision support moving forward. As we release decision support tools on the app, we'll be releasing our citation references on the website as well. Let me move back again to the main part, and we will look at a few other areas. First, you'll see pediatric diagnoses, and you'll see bipolar disorder here as well, with a full pediatric bipolar decision support tool. We'll go back again, and under the perinatal and women's health section, bipolar is now broken up into preconception, antepartum, and postpartum. And so you can see here that there are specific postpartum recommendations. I'd like to highlight for the perinatal tools, we also enlisted a maternal fetal medicine specialist on our team, and we're able to work with 2 of the top perinatal psychiatrists in the nation. And so we couldn't be more excited about these tools. There's also a full substance use disorder section involving Suboxone, MAT therapy or MAUD therapy, alcohol use disorder, tobacco use disorder, and our benzodiazepine deprescribing tool will be available soon. So here's the website. You guys have seen kind of things top to bottom now, but let's look at the app. And I'm going to pull up the app on my iPad here and share my screen. So that was the Waco Guide website. Now we're really excited to introduce the app version. There is a preview version of the app currently available on the iOS App Store. Android users, don't worry, we are going to have the full version available in the coming months. In addition, the full iOS app and Android apps will be available this summer, but I'd like to show a few areas of the app right now. If you'd like, you can go ahead and scan the QR code on the app and download it, or search for Waco Guide-Psychopharm in the Apple App Store and download the app as we speak. So I'm going to go ahead and share my app screen now, and we can look at a few features of the app together. All right, so I have the app up now, and honestly, we couldn't be more excited about sharing the Waco Guide to Psychopharmacology and Primary Care app. This takes all of the logic and those decision support tools and turns it into a functioning app. And so I'm going to show a few other areas. Let's look at bipolar again. So I'm going to select bipolar disorder here. We'll select adult and move through a few pre-treatment questions. So let's say this patient is unfortunately manic in front of us right now. You can quickly choose what medicines they may have been on previously. So is the patient currently or previously on medication? Let's say the patient is currently taking risperidone, and it's a current medicine, and it's unsuccessful at this time. So we input our medicines and we can click next. And the app is going to give us a recommendation on how to treat the patient in front of us at this time. It's going to give a strength of recommendation, and then we can click on that option here. So again, that's a sort A recommendation, like we shared before. And then these plus options down here, let's say we choose to treat this patient with aripiprazole, give us the same dosing recommendations, FDA box warnings. And then moving down, you can see the decision support tool like you saw before, as well as the key recommendations on the bottom. I'm going to reset this patient now though, and let's say they have bipolar disorder and they're manic again, but let's say they also have hepatic impairment. This is a patient with cirrhosis. So again, I'm going to select manic. I'm going to select no medications at this time. And now we have another treatment recommendation, but you can see it's different. So there's severe and less severe symptoms. And you can see here that a few of these medicines we need to think about importantly in somebody that has cirrhosis or hepatic impairment. So please see medication details for guidance is what that yellow sign means. And I'll open up Risperidone now, and there'll be some specific reasons that this medicine may be more or less ideal in this population. So you can see here in a patient with hepatic impairment that there's specific Child-Pugh Class A dosing recommendations. Again, I'll go back to the main screen of the app. And so you can see here that right now, the preview version has bipolar disorder. In the coming weeks, you'll see GAD, panic, and social anxiety disorder. Major depressive disorder and PTSD should be available by early summer as well. And we plan to, over the next months, roll out all of these different disorders on our app version of the Waco Guide. So again, here's the QR code reader again, if you'd like to scan it to download the app, or again, it's Waco Guide-Psychopharm in the App Store. All right, now that we've gotten to review the Waco Guide, we'd like to go through a few cases to demonstrate and practice its use. So here's case 1, major depressive disorder. Miss Johnson is a 55-year-old female diagnosed 6 months ago with major depressive disorder. A thorough history and physical was performed at that time, ruling out alternate etiologies for her depression. Initial PHQ-9 was 21, and she denies SI, HI, audiovisual hallucinations, or mania. She was initially referred to counseling and started on sertraline. However, discontinued the medication due to GI side effects. She was then trialed on escitalopram and titrated to max dose, where she developed a partial response, which is reflected in a PHQ-9 decrease to a score of 14. She feels escitalopram has been beneficial and desires further pharmacotherapy. Using a Waco Guide, how would you recommend her further? And so you all can access the Waco Guide through a number of ways. I've pulled up here the wacoguide.org website that we looked at just a second ago. I'm going to click on the guide, adult diagnoses, and depressive disorders. And here's the major depression decision support tool. I'm going to give you all a second to do the same. And then we can come to an agreement potentially on a medication to choose to augment or to treat her partial response further. So I'll give you all about 10 to 15 seconds or so. So if you haven't come to a next step yet, that's okay. In the interest of time, I'm going to go ahead and go through the Waco Guide, how I would look through this tool. And so I'll zoom in a little bit here. So let's just walk through. She presented with severe depression. We treated her with combination psychotherapy and pharmacotherapy and used a first trial of an antidepressant, which is a SORT A recommendation, if you're familiar with AFP's taxonomy for strength of recommendations. We prescribed sertraline. We followed up every 2 weeks, titrate as appropriate, and she had an inadequate response due to intolerable side effects. And so we moved to a second trial of one of those first choice medications, and that's a SORT B recommendation, followed up and titrated as appropriate, and then she developed a partial response. So we can see here partial response, and she desired further pharmacotherapy. So the recommendation is to continue current antidepressant and augment. That's a SORT B recommendation. And you have a couple options for augmentation therapy. And the first choice for augmentation therapy, we have 2 categories. One is to use aripiprazole. Aripiprazole has a unique benefit in the multitude of studies that does not seem to be a class effect that is specific to aripiprazole. Or you can add an antidepressant from an alternate class. If they're on SSRIs or SNRIs, like our patient, then bupropion or mirtazapine may be a reasonable option. So, there's multiple options in the case presented to us, and all of these will be reasonable, tailored to that patient. Case number 2, bipolar. Mr. Edwards is a 34-year-old male diagnosed with bipolar. He reports current symptoms of depressed mood and reports his last manic episode was at 24 years old, involving 10 days of not sleeping and developing grandiose plans to open up a chain of taco stands throughout the DFW area. Thankfully, his roommate intervened prior to financial losses. He recalls being started on a medication for mania, which he took for about 9 to 10 months, but then stopped it and he can't recall the reason why. He presents to clinic today reporting significant depressive symptoms for the past 7 months, which are negatively impacting his relationship with his wife and performance at work. He denies mania, auditory visual hallucination, SI, and HI, and you rule out alternate etiologies for his depressive symptoms. Of note, his BMI is 38. He desires further pharmacotherapy. Using a Waco guide, how would you guide him further to treat these depressive symptoms? All right, so I'm going to go ahead and pull in the decision support tools. This is the Waco Guide website. Here is bipolar and then bipolar obesity. Again, I encourage you to follow along on a phone or tablet or computer and do this yourself as well. So I'm going to go ahead and click on bipolar obesity. And you can see here that there is a depressed and manic arms, and let's just move top from bottom. So we're going to evaluate for SI, HI, among other things. Those are not present, so we'll move down to evaluate current symptoms. And the comment maintenance therapy indicated in majority of patients with bipolar is something good for us to keep in mind. Does the patient have acute mania or a history of recent or severe mania? Well, no, his mania is in the past and he denied current mania, and his presentation is not consistent with mania as well either. So then we're in the depression arm and we need acute treatment. And then we ask, was he successfully treated in the past? Well, he was successfully treated for mania, but he wasn't successfully treated for depression in the past. So we'll say no here. And then ask, is the patient currently taking an atypical antipsychotic for mania? He's not. And so we're going to look at our 2 first choice options, which are atypical antipsychotics and lamotrigine. Out of the atypical antipsychotics, there's 2 that are recommended, lorazepam or quetiapine, with the note that quetiapine does have a yellow sign here. A yellow sign indicates a caution, and the caution here reflects his morbidity risk due to obesity and this having a high association with metabolic abnormalities. That is then stated in some other areas as well. Referred antipsychotic side effect management decision support for recommendations on mitigating metabolic side effects or atypical antipsychotics. So there's a separate decision support tool addressing this specifically, which you can find on the website. I'll show in a second. And then if we scroll down to the second page, here's quetiapine. And there's a specific note here of why this is caution signed. High association with weight gain and metabolic dysfunction. I'm going to go back here then, and we can look at that same atypical antipsychotic side effect management for metabolic and medical disorders. And there are a whole arm here addressing metabolic issues and weight considerations of how to think through these atypical antipsychotics. For this gentleman, though, it seems like that lorazepam or lamotrigine may have been our first choice options given his obesity. Let's move to another case. Case number 3, antepartum bipolar. Miss Roberts is a 31-year-old female with a diagnosis of bipolar disorder. She was diagnosed with bipolar at 25 years old after a manic episode resulting in psychiatric hospitalization and was started on valproic acid. She was subsequently placed on a LARC, an IUD, by her OBGYN. She remained stable in this for a number of years. 6 months ago, she saw her OBGYN to have her IUD removed in order to attempt a pregnancy with her husband. At that time, her OB physician instructed her to begin prenatal vitamins and valproic acid supplementation and to stop valproic acid and to contact her PCP to discuss what medication, or if any, is reasonable to treat her bipolar disorder. Her IUD was removed at that time as it had expired. She now presents to your office 5 months since having IUD removed and being off valproic acid and reports she is 8 weeks pregnant. She is euthymic, taking her prenatal vitamins and high-dose folic acid, and denies SI, HI, or ABH. She has not had a manic episode since being 26 years old. She wonders if she should consider pharmacotherapy during her pregnancy, even though she's euthymic. Using a Waco guide, how would you recommend her further? All right, so for this scenario, let's go ahead and use the app. So I pulled up the Waco Guide app. If you guys have had a chance to download it, I'd recommend go ahead and doing the same. As we move through here, I'm going to input bipolar disorder, adult, reproductive age women. You have the option for preconception counseling or women of childbearing age, antepartum or postpartum. I'm going to select antepartum. then the question is, how is the patient currently presenting? We'll go ahead and select euthymic at this time. And then there's a question, does the patient have a history of recent or severe mania? This is a clinical subjective question that involves a discussion with you and the patient. Our patient was 25 years old when she had her last manic episode. That was 6 years ago because she's 31 now, but it did require psychiatric hospitalization. So we'll go ahead and say yes. And so we then have the option to input any medicines that were effective. So let's say that she was on medicines previously, that she was on valproate, that was a prior medicine, and that it was effective at that time. And then I'm going to click next. The recommendation here is avoid taking valproate, ensure she's on folic acid 4 milligrams, and then recommend one of these two medicines, quetiapine or aripiprazole. And if you'd like to look at doses further, you can expand those to look at exactly which dosing that should be considered for that patient. And here's aripiprazole as well. What's unique about this decision support is that in a regular adult, we'd often say, well, gosh, if a medicine was successful for her previously, go ahead and use that medicine again. However, for her, because she's pregnant this time, valproate would be contraindicated. Let's go ahead and move to another case. We have two more. Pediatric generalized anxiety disorder. Samantha is a 14-year-old female who you have been seeing for the past 12 weeks for generalized anxiety disorder. Her anxiety is debilitating at times and negatively impacts her school performance, attendance, and friendships. A thorough history and physical was initially performed, ruling out alternate etiologies for her GAD. She denies SI, HI, AVH, or mania, and her mother has a history of GAD as well. Given the severity of her symptoms and via shared decision-making, you, Samantha, and her parents determined that pharmacotherapy is in order in addition to referring for cognitive behavioral therapy. You start on fluoxetine and titrate every 2 weeks to a max dose of 80 milligrams. After 8 weeks at this max dose, she's had an inadequate response. Using a Waco guide, what pharmacotherapy would you consider next to treat her GAD? So again, I'm going to pull up the Waco guide, but I'll go back now and we'll select pediatric and GAD, pediatric GAD at this time. She had severe GAD, which recommend combination CBT and pharmacotherapy. So we chose an SSRI here, and we chose fluoxetine, followed up every 2 weeks, titrated appropriately, and now she's at max dose and has had an inadequate response. And so the recommendation here then is to choose a second choice, try other SSRI. So we can choose escitalopram, fluoxetine, or sertraline. If we move down to the bottom then, here are dosing recommendations for those three medications. Let's move on to our last case for today, alcohol use disorder. Mr. Jones is a 48-year-old gentleman you are seeing in clinic for a hospital follow-up for delirium tremens. He completed an inpatient benzodiazepine taper and was referred for a 12-step program upon discharge. He has a past medical history significant for hypertension, as well as child Pu-B alcoholic cirrhosis that was just diagnosed during this delirium tremens hospitalization. This was his first time being hospitalized with DTs, and due to his DT hospitalization, as well as his recent diagnosis of cirrhosis, he is motivated for long-term alcohol abstinence. He asked if pharmacotherapy would be a reasonable option for assisting him in cessation. Using a Waco guide, how would you recommend he proceed further? So again, I'll go ahead and pull up the Waco guide here. And one of the sections is a substance use disorder section. Significant guidance revolving around opioid use disorders, but we're going to move to the bottom for alcohol use disorder. And under the alcohol use disorder, there's two decision supports, the alcohol withdrawal, which would have guided us to hospitalizing this patient, as well as the post-withdrawal treatment. So I'm going to go ahead and zoom in on the post-withdrawal treatment and see how we could help this gentleman further. So we're going to evaluate and treat for comorbid mood disorders simultaneously with referring to a 12-step program, and also consider pharmacotherapy and ask, does the patient have a subgroup indication or contraindication to certain pharmacotherapies? Well, he does have hepatic impairment. He has cirrhosis. And so due to that, we are going to choose acamprosate to help him with long-term alcohol abstinence. If he did not have hepatic impairment, no over here, then naltrexone would have been our first choice option. If abstinence was achieved, then we continue the acamprosate for minimum 1 year. But if it was not, then there's some further guidance on how to proceed further. Again, towards the bottom is dosing recommendations, common side effects, and specific notations about that medication. So sometimes at different presentations of the Waco Guide, we've been able to really sit down in smaller groups and think and brainstorm together about other areas of medicine that decision support tool development may lend itself. And I think there's a lot, anything from HIV care to inpatient pediatric care. There's quite a few areas. And of course, Zoom talks and doing a sort of recorded session doesn't make it as easy to be able to brainstorm as groups. But I encourage you all as you walk away or have breaks today to think about other areas where this type of tool development can be really beneficial. We're really excited about clinical decision support tools and especially excited about the application of psychopharmacology. I'd be remiss if I didn't thank the team. So huge thank you to the other associate editors and special contributors to our team. Lastly, I'd love to share, here's our email address, wacoguide@wacofc.org. We love speaking to other clinicians about the Waco Guide, psychopharmacology, and psychiatric care. We really view this as a living tool, and when new updates or guidelines are available, this tool is adjusted for those as appropriate. And then this also really serves as an internal peer review tool. We've had many clinicians share, hey, what about this in this area, or this specific recommendation? How is it interpreted or applied in this area? And we love to have that internal dialogue and feedback about the tool. And so we really appreciate y'all's time today. We look forward to talking about this further, hearing feedback from you all, and hopefully seeing others use the Waco Guide to psychopharmacology and primary care in their practice and their organizations. Thank y'all. Take care.